So welcome. This is the first in this room of plenary meetings for this afternoon, and we're going to be talking about managing challenging behaviors. And so what we've done is brought together 3 total, but here we have 2 experts in different fields. And we wanted to do that because we wanted to represent the full picture of possible approaches to behavior. And so who we have here today is an occupational therapist with experience working with children with neurodevelopmental disabilities. We have a psychiatrist, and we have a behaviorist who will be joining us. And so let me do a more formal introduction. I'm going to sit down and refer. I have a list of questions, and that's how we're going to do this today. We're not going to be talking at you. We're going to be taking questions from you, taking questions online, and we've taken questions from you already that we've curated to prepare and talk about today. So my name is LeeAnne Green Snyder. We'll start there. I am a clinical psychologist. I've been working on Searchlight for a long time. I'm supposed to go over some housekeeping items with you before we get started. So throughout the discussion, I'm going to be asking questions that were submitted ahead of time. I mentioned that. We're going to invite you to ask questions at the end of those questions. We have staff with a microphone. There's a mic there in the middle that you can use. And we're also taking questions that will be submitted online for those for folks that are joining online. So when you're asking questions, please try not to include super personal information in your questions. We're not able to give super specific treatment advice about your child or your loved one here. Everybody is unique. They all have their own unique situation. And for good treatment advice, you would need a one-on-one with someone to properly address that unique situation. We also want to try to share information that would be helpful to everyone here. So we've welcomed everyone, and we want the information to apply to as many people as possible. So what we've done with the questions that have been submitted so far is to extract some themes for issues that are frequently mentioned, that come up quite a bit in our communities, and we're going to try to speak to those. The speakers will also be available at the fireside chat at the end of the day at 4 o'clock. Okay, so here, joining me today, we have Dr. Raj Mahajan from Kennedy Krieger Institute. He is a child and adolescent psychiatrist at the Center for Autism and Related Disorders, and he is also assistant professor of psychiatry at Johns Hopkins University School of Medicine. He's board certified in not only child and adolescent, but also adult psychiatry. And he has a longstanding interest and experience in neurodevelopmental disorders and evaluation and treatment of co-occurring disorders and problem behaviors in children with very complex presentations. And here we have Tally Foster. She is coming to us from Ability Plus Therapy. She's an occupational therapist with 26 years of experience, currently working with kids and families of children with physical, sensory, and developmental differences and various complex neurological and medical conditions. So we welcome them and thank you so much for joining us today to talk. So we're going to, if you're comfortable, we can take masks off if you would like, so people could hear and see us, but all of you, as usual, please keep masks on. We just, being up here, we want you to be able to hear and see us. So let's start with one of the inspirations for this talk. Families asked us to target restrictive and repetitive behaviors in particular. That can mean a lot of things. So I'm going to start with a question that came in online when we opened up question submission. And this would be a nice opportunity for you each to talk about how you first approach a problem such as this one. So a parent wrote, one of our biggest behavioral challenges is transitioning. So this is everything from small transitions between activities, so from one task to the next, or maybe from a preferred task to a less preferred task, and also big transitions like going from place to place, leaving the house to go to a therapy appointment. And these can become full-on meltdowns. So I think a lot of us can relate to this. And so the question was, do you have suggestions for how to ease and aid transitions? And so, Tally, let me start with you and your thoughts on how you typically approach this kinds of issues and how someone from a sensory integration perspective would tackle this.
Hi, everybody. Can you hear me first? I don't know. Yeah. Okay, great. I'm also usually very loud, so I'm excited to be here. Thank you all. It's so great to see so many families. So just to kind of give you an intro to the approach before I answer the specific question, from an occupational therapy perspective, with this sort of concern of this population, we're looking at things from a very strongly from a sensory perspective. You're going to hear obviously other collaboration and takes on that. We put all of these ideas together and we hopefully see the best result, right? So my contribution today hopefully will be from that perspective and helping us understand how we can help in those ways and help guide those skills and those factors. So first of all, to discuss transitions, you can first think about what transitions was moved just now, right? We all do things to help ourselves move from one place to another. Whether they're small, it's a lot different when we're going to transition to maybe the airplane to fly home, right? A lot of factors and components. But the biggest thing is there's preparation for that. You have done special preparation for new situations, but you have your regular things, right? So you want to rely on and develop those skills over time. Your children need that ability too. And they learn that from us, and they learn that through practice, which sounds obvious, but we sometimes kind of take that for granted. And practice should always try to hopefully occur before we're at the game, right? So rehearsals. So you want to be able to implement and practice any of the sensory strategies that they need to be able to know of an upcoming transition, handle the actual transition. The things we can control. The things we can control are the regulation components for the child and what they need, and we'll get more into that, I'm sure. And that's for the individual. The environment and the tools that we can have with us for each kind of scenario. We might have car transition things, you might have school transition things, you might have travel to out of town transition things, a lot bigger picture, right? And then we can modify things for them. So lessen or reduce demands as possible, which causes us to need to prioritize, right? So there's a lot of details we're going into, but just start by thinking about those foundational skills and what aspects will help with that. Go on.
That's great. Yeah. So I want to follow up. So that's great. So I'm hearing prepare and practice. Control, have some control over your environment. What can you use for tools? So whether transition things, I'm thinking transition objects, reducing demands on the child. So thinking about how to do that and how to help their self-regulation. Okay, so then can you just give an example of a type of transition object that you might recommend that would prepare someone to move from maybe a preferred activity to a less preferred activity?
Right. So one other thing I didn't mention. So also as much information as we can give them and scheduling routine is preferred. I know that doesn't always happen and things change, and that's kind of a variable. But whenever we can, try to give them, whether it's a picture schedule, whether it depends on what they can handle. So if they just need to know the next event ahead of time, giving them that moment to process what's next, and then reinforcing it before it happens. But an actual object might help them have that clue too and use as a tool. So maybe there's an example could be we're going to the car, and that means that they get to carry Mommy's keys to the car. And they kind of know, like, I'm in charge of this. It has to be something appropriate and safe for them, but whatever it is that can be, and it might also serve the need of it's something they hold on to and they can fidget with. It might be a weighted stuffed animal. It might be a song you play on your phone. That's just something that gives them that gift. So giving them something to associate with the transition then helps them know it's coming each time, but hopefully it can meet a sensory need as well. So that can be anything that's feasible and manageable for that situation. It also has to be something that works for you. That is super important too. It's not a one size fits all, but it could be small. It could be something very seems minor, but could have a big impact.
That's great. That's very helpful. I think that that's something tangible and concrete that, that we can learn. So actually thinking about having those objects ready to transition a child, a person from one thing to the next. Raj, I wanted to ask you, at the point where maybe we've tried supports like, the kinds of transition objects that Tally was just talking about, trying to prepare them with a picture schedule and putting in other kinds of supports into the environment. If the child just seems to, individual seems to be unable to, calm themselves down, like it seems like nothing has worked, then how do you look at this problem if somebody comes to you with this problem from a medical perspective?
Sure, thank you. First of all, it's my pleasure to be here and to talk to all of you. I am a child psychiatrist, and when I am some patients with neurodevelopmental disorders, I'm not just thinking about medications, and I just just to get information. And like, for example, in the first time I see the patient, I understand the context in which behaviors are occurring. If there is a medical concern, take that into consideration. As if the child is on medications, consider medication side effects. So it's a more broader understanding of the patient, which can sometimes take time. As far as problems with transitions are concerned, they can be due to many reasons, and they can be due to sensory sensitivities, but also anxiety and learned behavior. And so I also take that into consideration. I will use an example of, for example, a child has to go to for blood draws, which is a huge problem for many kids. And how do you help them have the blood draw? They might have fear of needles. They might have fear of just going to the lab and have the blood drawn. And I don't just jump to medications first, but also consider, anxiety, situational anxiety, phobias. Sometimes these phobias may run in families. You might have parents with the similar phobia, and the child may have the same problems. So I'm fortunate to work in a system where we can actually refer patients to colleagues who specialize in sometimes even, for example, sensitization for blood draws, or helping with medications, swallowing problems, things like that. So I think about behavioral approaches first, and then if the symptoms are severe enough, I've had kids over the years that we've tried everything and nothing has worked. All non-pharmacological approaches have not worked. Then we think about medication. So sometimes we think about, what is the medication that would be most beneficial with less side effects. And so sometimes medications like Benadryl which are available over the counter, or sometimes prescription medications like, for example, hydroxyzine. Those kinds of medications that are, they don't have a lot of side effects, but they can reduce anxiety. So sometimes I prescribe those, but if the anxiety is severe enough that it's not, it's not working, we've tried hydroxyzine, we've tried Benadryl, then we think about other medications. And that leads to a bigger question of not just the problems with transitions, but also, is there a baseline anxiety that the child has that needs to be addressed? Or is it just situational anxiety? So thinking in terms of context as well as more specific reasons for the refusal for blood draws, etc. So, and that requires collaboration with parents. Parents know their children the best, and so it may take some time to get to know the child better. And so it's communication with the parents about what their child, thinking about transitional objects, etc. So taking all that into account and using colleagues who might be able to use behavioral approaches to help with desensitization, and then medications. Sometimes, that may be the approach to take. So it is you have to look at the bigger
It's
picture.
complex, it's a big picture. And so I'm hearing, think about where they're going. Is there some specific anxiety or phobia attached to? Is there something, very wrong in their minds about where they're going and what you're asking them to do next? Are they coming at it with an underlying anxiety that's there about a lot of things? And then consult with the doctor if it's very difficult to control. So on that note, you mentioned behaviorists that can do desensitization. So I want to introduce, we're very happy to have Dr. Nathan Call, and he's from Emory University School of Medicine. He's professor of pediatrics, and he is the associate chief of the Division of Autism and Related Disorders at Emory. So he's very active in research, very active in publishing many papers on challenging behavior in autism, autism-like behaviors, which we're talking about today, which applies well beyond autism, and that's the repetitive restrictive behaviors and related disorders. So welcome to Nathan, and do you want to just open up the line of thinking? What we were saying is, like, this is our first question, and this good way to show an example of how we each in our different disciplines come at a problem.
Yeah, so first of all, tremendous apologies for being late. My calendar said this was happening at a different time for some reason. So I was sitting there having a lovely interview with somebody for a job that is a little confused right now because I took off. Sorry, I gotta go. This is much more important. So he's a little confused, but that's okay. We'll get that back under control. I really want to echo what was said already when it comes to things like transitions. When I think about approaching challenging behavioral from a kind of a more behavioral approach, first and foremost, as was said, you got to look at the whole picture, and part of that is making sure any underlying medical concerns are being addressed. So kids who are experiencing pain or discomfort from like dental pain or constipation or any number of things can cause all of us to be a little bit more irritable and react differently than we might when we're feeling well. And so those things, whenever possible, need to be addressed to the extent it can be. When it can't be, that still means that you can go forward with trying out other strategies, but it often becomes more about trial and error. And then another thing that I would really try to hit home on is that any good set of behavioral recommendations that augment what's being talked about from a medical standpoint really should have 4 components that are part of it, and they'll be accentuated to differing degrees depending on the situation, the behavior, the kid, and so forth. But really, what I tend to think about is, first and foremost, we talk with families about identifying what I would call preventative strategies. So those things that you can do that make sure that the behavior doesn't happen in the first place. My experience has been families are often pretty good at this. I remember I worked with a family not too long ago. They walked into an intake and the kid had 13 screens with him. He had 11 iPads and 2 iPhones. And the reason he had 13 screens because I watched right in front of me him bend in half an iPad with his bare hands. Which I don't know you could do. Those things seem pretty tough to me. But the family had basically learned, keep him happy with screens at all times. They had to sneak into his room at night to charge him because he was so protective and just wouldn't let those things go. But they'd been very proficient at just learning, as long as we keep all the screens around and keep him charged, he's in a happier place for the most part. But that can also, so that's kind of one extreme, is just remove the reason for the behavior happening in the first place when you can figure out what that is. And in his case, everybody knew it's all about the screens, friend. So as long as we keep him swimming in screens, he seemed to be okay. But those preventive strategies can also extend to the types of things Tally was talking about, which is if we know that this is an anxiety-provoking situation, if you know that going to get a blood draw, if you know that going somewhere that's not preferred is going to be anxiety-provoking, what are the things you can do to increase predictability? I love that she brought up transition objects. We got a little chance to kind of screen some of these questions ahead of time, and she stole all my thunder because those are exactly the kinds of things that we would recommend too. So things that you can do to prevent the behavior from happening in the first place. The great news about those is that they can be really effective. The downside is you're always going to find that time and place when they don't work, and then you're kind of stuck, right? So, you know, the example of the kid with the screens, like, you know, that's everybody's happy as long as he's got a screen. Till the power on the 13th one dies, the batteries die, and then you're kind of up a creek, right? But still an important tool to have in your arsenal. Another piece of that continuum of treatments, though, or strategies, would be what we would call more behavioral interventions. These are the things that we are hearing about as far as systematic desensitization or teaching communicative replacement behaviors, stuff like that. These generally rely on teaching. So teaching a child to tolerate a situation that they don't already, or teaching them to comply with tasks that might be aversive, or teaching them to communicate instead of use problem behavior as a form of communication. And those, over the long run, reduce the probability that when you're in that same situation next time, the behavior will occur, but they rely on learning. They rely on learning to tolerate something by usually very gradually increasing something, taking a step back, getting things under control, and then gradually working forward again. So long-term, that's often the right approach, but you kind of have to be able to get through today too. And that's where some of those more preventative strategies are important. Then I would say the other thing that we try to recommend for every family is that they have what I would call mitigation strategies. These are the things that you would say, well, a certain amount of this behavior is just going to happen. How do we make sure that when it does, everything is okay? So a child can still make progress on their IEP goals. You can still go to the store and not have to leave a cart full of groceries and walk away from that, right? How do you get through the day so that if that behavior happens, nobody's being injured and so forth? And these are oftentimes things that you can do to set up the structure of the environment to allow the behavior to occur, but stay safe. And then the last category would be what I would call crisis management strategies. These are the strategies, you know, I work in a field where a lot of people in my discipline, they're all about that second category. We're going to teach you how to not engage in this challenging behavior, which is all well and good, but it doesn't recognize the fact that sometimes stuff just hits the fan and you got to stay safe. You got to get a dangerous situation under control as quickly as possible. And so that oftentimes means having strategies in hand to just extricate yourself from that situation quickly and safely, even if it means kind of from a long-term perspective, doing what you wouldn't necessarily recommend. My one big thing that I talk to a lot of folks about is when we use those crisis management strategies, we always tell folks, but you only get to call that specific situation a crisis one time. Because once you've been in that situation and you've seen that that's in the toolbox, the kids' toolbox, they can pull that out when they need to. You've got to therefore thereafter come up with a plan to handle that the next time around, so it's not going to reach that same crisis state. Let me just give you an example. I went to a classroom not too long ago, went to a school, and the teacher said, oh, I'm not going to use his real name. There goes Johnny again, crisis mode, everybody. And they just gave Johnny exactly what he wanted so that he would calm down, essentially teaching him how do you get what you want, and make things bad enough for people and they'll give you the thing that you want. But it was like 7 crises every week. And instead of just figuring out a way to work with Johnny in a way that he actually was learning skills and being able to get through the situation without escalating, they just called it a crisis every time. And we would say that's not really an effective approach, right? That once it's happened one time, now it's on you. Everybody gets a pass, but once you've had that happen, it's on you to figure out how to work through that situation going forward without necessarily reaching that same crisis state. So those would be kind of 4 strategies. And again, accentuating each of those to differing degrees based on the time and circumstances and the individual and the behavior. But when I feel like my team's doing our best work, we're really arming parents with all 4 of those components for each of their kids. So real quick synopsis. Maybe not quick, but a synopsis.
That was a really good synopsis. So, I mean, if it isn't obvious already, it's hard for us to dig in and be super specific, like we can't teach the skills which take, I mean, can you just give us an example, Nathan, of like when you're working with a family, the scenario you just gave, okay, now we know that this was a crisis, we don't want this to happen again, let's work on this behavior because we know it's in the child's arsenal of behaviors, they might pull it out again. How long might it take to work with a family one-on-one, like with really specific sessions, you know, to be able to work on that? In other words, we can't solve it today here, but just want to give people a sense of how to undertake treatment with someone who works with behavior.
Yeah, I think that using the example before of transition, so we have a group that, you know, we have a research study right now underway for elopements, you know, kids who wander away or run away during, a lot of time during transition times, right? Now, I remember we presented some of this research at a conference the first time and everybody said, I didn't realize kids were running off to Vegas getting married. And we had to explain, no, this is about like any kind of leaving supervision counts as elopement. Usually I get bigger laughs when I say that, but all right, there we go. All right. Yeah. But the kids who run away or wander away, super dangerous. It's the leading contributor to the fact that kids with developmental conditions have double the premature death rate of their typically developing peers because they fall into bodies of water, they get hit by cars. So it's super dangerous. And so thinking through like, what does an approach like that look like? Well, the first thing is to really understand the why. I think that's what we were hearing just a minute ago. So kids run for lots of different reasons. And you approach each one of those strategies differently depending on the reason the child's running. Some kids run because they're running to something. You know, you're at the grocery store and you walk past the candy aisle and they're gone, right? And that's where they want to go and they're running towards something. Other kids run from things. So it's time to brush your teeth, my friend, or it's time to do homework or whatever. And they take off running or they run out of the classroom. And then some kids run because they just like running, right? You know, I always think those kids, if I could get in their head, just the wind in their hair on a beach, just love to just take off. Some kids love the reaction that they get. I had twin brothers one time who both nonverbal, both would run. And although they didn't speak, you swear that they had this pact, right? Like, I'll go left, you go right, mom can't catch up, right? And just to watch mom chase us is hilarious. And so each of those take a different approach. Kids who run to things versus kids who run from things, but kind of doing a little bit of investigating or logical investigation to figure out, well, is this about running to things? Well, in that case, how do we approach this so that the child, you know, we had a child who would run to balloons, and that was his favorite thing, just loved balloons. He was actually hit by a car on his first day coming to our clinic because the rental property across the street had big balloon displays, and he was running towards that, and it was his fourth time being hit by a car, his mom said. She was kind of pretty chill about it. She's like, well, the third time didn't get him, the fourth one was no big deal. And he was okay, but in that case, it really meant we knew it was about balloons. So then that meant we would use, again, some of those same strategies. First thing was, hey, look, if you're going into a situation where it's dangerous, keep a pocket of balloons, you know, and he liked to inflate them and pop them. That was his whole thing. And he could do it faster than anyone I've ever seen, but he could inflate it and pop it. And she would go to the store and keep a pocket full of balloons. And that was a more preventative strategy, right? So that you can get through your day and stay safe. And while you're working on other strategies, you can get through that. But it also then meant a behavioral intervention of teaching him to request access to balloons. And initially he would ask, and we would give him one every time he asked. And a lot of times these strategies may take a big step back. That's not where we want him to be for the rest of his life. We had to take a step back and say, look, we just got to get control over this and teach him some skills. So he didn't have a lot of language, but he was able to learn to request a balloon. We would hand it to him. He'd inflate it, pop it, and then pretty quickly he was just handing these things over. But over time, taught him, and that came pretty quickly for him, you know, because it was something he cared about a ton. We're talking about a day or two. But then it became a matter of he would request a balloon, and we had a signal that said, if you know, I think it was like a stop sign and a go sign. And when the go sign was up, if he requested the balloon, we said, nice job asking, but you can't have that right now. And initially it would be like for 2 seconds. And then we put the green sign back up, and then we'd flip it to red, and he would have 2 seconds where he couldn't get it. Sorry, with the stop sign, and then it'd be go. And then if he asked, he could get it and stop, couldn't, couldn't. So that he learned that when the green sign's up, I get what I want if I ask appropriately, but when the red sign's up, I don't. And then gradually over time, teaching him, you know, increasing the amount of time that the stop sign was up while we kept the amount of time that the green sign was up about consistent. And that would take a couple of weeks of real heavy investment of time and energy, but got to the point where my favorite part of the job is doing the final exam. So what do? We take them to the mall on Valentine's Day when there's balloons everywhere, right? You have to stay in proximity to mom and you can request when he was able to. And he went up 45 minutes between requests and she could give them that, but they could do part of their day. But
Wow.
that took several weeks of intensive intervention to achieve that point. So that's that second behavioral intervention piece, and it is time and labor intensive.
And if
Wow.
I can add
Yeah, please.
something, so in these situations, again, going back to, is it purely behavioral or is there something more than behavior? Is there an underlying co-occurring condition? And one of the symptoms that, we often have to manage is impulse control. And some of these kids who, they may be nonverbal or they may, they are running out because they are unable to control their impulses. And they have, for example, ADHD symptoms. And sometimes parents are not thinking about ADHD in a child who may be nonverbal or may not be able to communicate. So that's where, and ADHD in kids, I'll use autism as an example. In kids with autism, the two most common conditions that we see are ADHD and anxiety disorders. And frequently these may coexist. So when you have ADHD, the most problematic symptom is not the inattention or the hyperactivity, it is the impulsivity. And when you combine that with anxiety, situations where they may be running from, or it becomes like an avoidant behavior, and that can be really dangerous. I've also had situations where kids are running out of the house and parents have had to put changed locks on the doors, and take, sometimes parents, they're sleeping in the living room just to keep an eye on the door so the kid doesn't run out of the house. So if it becomes a pattern of behavioral approaches have been tried and they're not working, then having a very thoughtful evaluation for co-occurring conditions should be done. And if there are ADHD symptoms, if there is anxiety disorder, those should be treated, whether using non-pharmacological approaches or with medications, especially if it's becoming a safety issue.
And I wanted to add that I think it's so great to see this combination right here, because it's my favorite. Kind of putting it all together is the most effective thing if needed. And we're talking about a lot of things that involve learning skills, right? So whether you're learning how to use behavioral strategies to build new skills, whether we're talking about regulating sensory needs, if there is an underlying piece, it may be necessary for them to be able to do the other parts, right? So it's not a one size fits all, but complete respect to when that's needed, because we all face those situations where it's not about selecting one and only approach. It's really about seeing what happens when you combine the right things. And it may be that if you manage those underlying things from a medication standpoint, then you see a new opportunity to develop learning of behavioral strategies. It might just move the bar a little bit so that they now have the ability to have enough impulse control to learn a new skill, because it is a skill. Everything that we're asking them to learn is a skill that you're not born with. So it just develops at different times and at different stages for people depending on their challenges. And I just wanted to add one thing to what you said about your examples, which are very vivid, right? They're very familiar scenarios. And I think that the piece you mentioned about maybe that child's need to blow up that balloon and pop it, whatever they may be doing, or maybe running for the sake of running input, as you say, we want to break down everything they do from at least look at the sensory components it's easy to take for granted. We all function as sensory beings, and we put strategies in place constantly. You're doing it right now. You might be chewing gum, you might be moving your feet. You're doing things and taking and adjusting and modifying your input to regulate. Now you're doing that to regulate so that you stay in your chair. There are scenarios where we do it to stay awake driving, where we might need to be doing a much more demanding task. For them, we're asking them to do all different things too. So I just want you to look at what's required of them to be in a certain situation, and then look at if their needs are being met enough for them to be in that regulated state. So if they're showing us signs, and they often will through any means possible, and we're seeing maladaptive approaches to seeking sensory information or avoiding, it's important that we look at that. And by maladaptive, I mean, is it causing harm? Is it dangerous? Is it something that's inappropriate for the situation in some extreme way? We need to be very flexible, of course, and allow a lot of options. And that's our job, showing the world that people need different things. But when it's safe and it's okay, those are good things. It's good that they're regulating. So as long as we just make sure we are looking at strategies to support their behavioral changes, and we're including meeting their sensory needs, then it's a win-win all around. So I would say the other piece of that is that we often look at making sure we're helping them meet those needs proactively, as you mentioned, so that we're not making that only a reward. It can turn into, right? Like the balloon becomes the reward, and he learns and you progressed him there. But if he's saying, I need it because he needed like that heavy breath control, or he needed the sound, I don't know that child, but if that's what they need, then how can we have a way to make sure they get that before we ask demand of them? So maybe even in certain circumstances, we give them the strategy to use before we know it's going to happen, but that they're going to seek it in some way we don't want them to, like make sure that needs met. And it could be anything. It could be a sound, it could be visual, it could be movement, it could be running, it could be heavy work, whatever their profile is telling us they need. We need to make sure they're getting that sensory diet in their day, and how long it lasts and how much dosage. It's just a different way of providing input. So sorry, went on a minute.
No, it's not a tangent at all. I mean, I think that this is why I love having all of you here representing these different perspectives. So I don't think that all of us always keep the sensory world in mind when we're approaching. And the other thing is, I think as parents, we're reactive, right? So the child kind of throws something at us, either literally or figuratively, and we're reacting. Oh, what do I do now? But we have to always be scanning and keeping on our radar, kind of keep in our back pocket. Okay, what can we do first to kind of, ward this off? We're going to head things off at the pass. What do they need? Let's meet their sensory needs. Let's, meet their chill out needs. Let's consider, is there something driving, like Raj points out, is there something maybe driving impulse control issues, and keep that on our radar to know where is the individual coming from. And it's a hard job. It's a lot we're trying to keep on our minds to remember and anticipate before we get into trouble with the behavior. So I'd like to open it up to questions. I can't believe how quickly this time is going. Would anyone like to come up and ask a question? Could either add to something that we've been talking about here, or ask for more detail, or maybe you have another type of behavior you'd like to ask about. If not, we can just keep going. We have a lot of questions that folks submitted. Well, did you want to come up?
Hi, can you guys hear me?
Yes.
I just wanted to ask what anxiety looks like in children that aren't able to express, may have intellectual disability or communication issues. I know what it looks like in typically presenting children, but what signs might we be missing?
That's a great question.
Yeah, that's a great question.
Do you want to start, Raj? Go ahead.
Sure. That's a great question. Thank you for asking that. So it depends upon the child, and it depends upon the age of the child. So whenever we are approaching any co-occurring condition, or when we are evaluating children, we are always taking into consideration how old the child is, And if there are, when I'm gathering information from the parent about, let's say, anxiety in a nonverbal child, so I am asking questions about specific situations. Are there particular situations where you see certain behaviors like avoidance or trying to escape? Does it happen when demands are being placed on the child, for example, in the classroom setting, where the teacher is trying to work one-to-one with the child, and the child it's increasing the anxiety. And so they will try to escape from the situation or avoid. And sometimes, it's just lack of cooperation, or it may be interpreted as oppositional behavior. But sometimes it can go further. It can become, the child can hit the teacher, or it may turn into, a bigger episode of aggression. And especially if there are also, let's say the child is younger and they also have ADHD symptoms. So that's when that impulse control problem will also manifest. So anxiety can drive the child impulsively to act and hit the teacher. So you might see increase in aggressive behaviors. If it, at other times, other children who may be nonverbal, they are not able to communicate. They are not interested in, for example, doing the task that they're being asked to do. You might even see a bigger outburst. They may have difficulty with regulating their behavior, regulating their emotions. And so you might have disruptive behaviors, you might have destructive behaviors. And so you might get this kind of history, but again, it may be driven by anxiety symptoms at baseline. In children who are older, because ADHD symptoms tend to improve with age, you may not see as much impulse control problems or escape type behaviors. It may be lack of motivation. They may not. They may dig their heels, and they may refuse to do certain things. So so you will see those kinds of symptoms. When I'm evaluating children for anxiety, I'm also thinking about, is the behavior seen in public places? Is the behavior seen in school? Is the behavior seen at home? So the context of in which the behavior is occurring is also gives a clue. If anxiety goes untreated, sometimes you can also begin to see parents get frustrated with those behaviors, and then you might see even the parents get frustrated. They may disengage a little bit, and so the child responds to it by engaging in more challenging behaviors or attention-seeking behaviors. So even in that situation, the underlying driving symptom might be anxiety. So there are different manifestations. So it depends upon the context in which the symptoms are occurring.
So it sounds like it's complicated. We're saying it's complicated, but you might need a one-on-one to figure it out. Is what it sounds like, and it's going to depend. Unfortunately, the answer might be it depends. So do you have examples that you'd like to talk about?
What I would love to mention here, because it is related to anxiety, and I think it's so relevant in this room and everywhere. But I wanted to mention something about regulation, and there's a term called co-regulation. And that is a precursor to what we all want for our children, which is self-regulation. And co-regulation is that process of children managing, I'm not going to say this as well as you guys would, but managing like internal stressors and environmental demands, but with a person who can help guide them, a safe person, if that makes sense. But the reason I like to mention that is that there's so many scenarios we see, whether it's, walking into a clinic to see us or just any everyday life scenario, where we see the effect that child's dysregulation or anxiety or in their behavioral response to that, what that effect has on their parent or their caregiver. And we all know what that does to us, right? So you end up there too, right? Sometimes potentially. And then that feeds off each other. They mirror what that energy is. So it's very important that when we're working on these skills, this skill development in the children and the management of that, if it is anxiety of whatever they're feeling in that situation, that we're making sure you're learning how to get that under control yourself too, because they need that guidance with whoever they're with to learn not only what that regulation looks like and feels like, but how they get there. So those strategies that they need to learn, you need to do first. And you need to do it with them. It's a journey, right? So whether it's deep breathing, whether it's removing yourself from the location, and we're going to go outside and we're going to look at the trees and feel the wind, and we're just going to take a moment, whatever's available, whether it's hugging a big stuffed animal, whether, whatever strategy works for both of you, or what you can model for them. And sometimes it just happens when you're learning to teach your child something that someone's told you to do, like we want them to take deep breaths, and then you have to do it with them and you go, oh, I feel better. So you're feeling the effects, they see those effects, and they actually, that's where, the basis of empathy. So they learn to mirror what you feel. So it's very important that when you start looking at regulation and strategies from the sensory perspective, that you're also implementing what needs to be there for both of you, for all of you, and it will carry over very well. So those, whether it's transitioning, whether it's all these other behaviors we're talking about, other activities, look at those pieces. Does everyone feel better if the lights are dimmer? Does everyone shift if we put a different sound in the background? Does anything else need to happen? Does everyone do better if they have a lot of heavy work activity first to kind of know where they are? So just include yourselves or their caregivers in the process so that you have kind of that learning experience for them. So I know that's big under anxiety, so I wanted to mention.
That's a really good point. I think that we don't take time to think about for ourselves as parents, and it's very difficult to do. And it was one of the questions that came in, actually. So whoever submitted that question, thank you, was how can parents keep calm in the face of behavior challenges and a meltdown? How do we take care of ourselves in that? So does anyone have anything to add about mental health and well-being for parents, staying calm, any other strategies? I think Tally gave us some good ideas for things that are concrete. Any other ideas?
I work in mental health as well. Support. Everybody knows what the other person is going through, maybe worse, maybe minor, maybe major, but everybody's going through the same thing with the child.
Hi, my name is Michelle. I also work in mental health. I work for a community mental health center, and I'm here translating. Support groups. Look for a support group in your area. If there isn't one, start one. It's so necessary because other parents are going through what you're going through. Sometimes a lot worse, and sometimes minimal, and sometimes to the max. But just being able to sit, coffee, and talk to someone on what you're going through, you give them advice, they give you advice, and it's amazing. So if you're going through something, look for a support group in your area. Call your local community mental health center, see if they have support groups. If not, try to start one yourself because it really, really works.
It's a great suggestion. Thank you so much.
I can add one more thing. So when I'm working with children as a child psychiatrist, I'm also interacting with parents all the time. And all of us will work with parents. And frequently, I have parents who are really stressed out, and there are so many things going on. There are questions relating to the child. They may be struggling with their own mental health issues. And once I get to know them a little better and they're more comfortable, I do bring it up in conversations. When I'm having with them, I will sometimes initially, gently suggest that maybe they should seek help for themselves. Sometimes parents become defensive when I say that. And so, But there are, after a while, after you work with parents, they know you, you know them, and they feel very comfortable when you say that, I would strongly recommend that you seek mental health treatment and even medication if needed, because you need to be available for your child to intervene when behavioral recommendations are being made. If you don't have the energy, if you yourself are struggling with anxiety and depression, you're not really available for your child to help them when the child is struggling. So parent mental health is extremely important. I say that to parents all the time, and families I've been working with for a long time, they know what I'm going to say about their mental health. So a lot of them, they do seek help for themselves, and that has an impact on how the child does. Because when as mental health professionals, when we are working with children, we are not just working with the child, we are working with the family system.
The whole family.
The whole family, and that is the context in which the child's symptoms may be occurring.
If anyone flew here, what did they tell you in case of an emergency before your child?
Mm.
It's not selfish, it's necessary. So you have to take care of yourself to be able to help them. And that is in the big picture, but also in any moment. So.
No, it's so important. And I was going to say the same, and it sounds so cliched. We've heard that recommendation so many times, and it's so hard to do, but important to find ways. And I think the support group idea is great, because then hearing how other parents do this and self-preserve and keep going, I think that's everything. And research and common sense and all of our clinical work tells us that having that safety net, that support group, and feeling that you have those people around you, that you have a community, it makes a really big difference. So if anyone is struggling with this, really, really encourage you to reach out and get connected. It makes a big difference. So we're out of time already. I think we could have talked all day. Thank you so much. This was wonderful. I really enjoyed hearing unique perspectives from each of your areas of expertise. I hope you did as well. We'll be around later at the fireside chat and around today at the conference if you wanted to follow up with any more questions. So thank you for attending today.